must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hi, everyone, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm one of your hosts, Stephanie Wyrock, and of course, I'm joined by my fellow co-host, Brandon Poen. F. Scott unfortunately could not be here with us tonight, so he will not be joining us. But today we are joined by some very special guests who are going to discuss the Step 2 Clinical Skills Examination controversy with us today. The Step 2 exam is an exam that is implemented within medical school to try to get you licensed as a physician. So today I'd like to welcome Dr. Hillary Johnson, a dermatologist from University of Iowa, Dr. Deland Wyrock, a resident physician at Yale University and Yale New Haven Hospital, and James Price, a medical student from the Medical College of Wisconsin. Thank you so much for joining us today, you guys. You guys have all done some really great work in the realm of advocating for the elimination of the Step 2 skills exam. Can you tell us a little bit about yourself and how you got to where you are today? And let's start with you, Hillary.
Thank you, Stephanie. It is my pleasure to speak with you tonight. I am a faculty member at University of Iowa, where I work with residents and medical students in a training setting in dermatology. I went to medical school, started in 1995 at Washington University in St. Louis, and then went to residency and fellowship and work after in the East Coast in New York City. Then I made my way back to Iowa for current work. I'm a clinical associate professor of dermatology there. Pleasure to be here.
And how about you, Deland? Give us your backstory.
So I went to medical school at the University of North Dakota in Grand Forks, North Dakota. After that, I matched into residency in pathology at Yale University and Yale Hospital, like you mentioned. Yes, I am Stephanie's husband. So we are a married couple. That's it for me. Thank you.
And James, tell us about yourself.
My name is James Price. I'm a fourth-year medical student from Neenah, Wisconsin. I currently go to Medical College of Wisconsin-Milwaukee. Just in January, I found out that I have a passion for psychiatry, so I hope to join a psychiatric residency next year. So M1 and M2 year, I saw the petition for Step 2 CS bouncing around Facebook, and around the same time I joined my AMA chapter, and I was soon after co-president of the Benjamin Rush Institute chapter at my school. So those two organizations both really focus on the empowering the physician and the physician-patient relationship. So as far as empowering the physician, I think Step 2 CS aligns really nicely with that, and putting power back with individual medical schools to evaluate their patients, determine what the curriculum will be, as opposed to a national organization testing it.
So guys, I know that Steph kind of briefly beforehand kind of gave us a brief introduction to the Steps to Clinical Skills Examination, but for those of our listeners, perhaps for different healthcare providers who are listening, who are perhaps really not aware about what this examination is, do you think you can kind of give our audience some background on what is this test, what is it supposed to measure, and how does it fit in with training to become a physician?
There's a long, complicated history to this test, but to be brief, there was a forerunner to the Step 2 CS exam in the 1960s. It was performed for a few years before they ran an evaluation and found that there was insufficient evidence to support the continuation of the clinical skills exam. It then re-emerged in the 1990s, but was only given to foreign medical graduates who were applying for residency in the United States, mainly as a test of communication skills, English language proficiency. Those metrics were the main reasons for giving the test and evaluating the student doctors. But then in 2003, 2004, that examination that had previously been given only to foreign medical graduates became mandatory for all United States medical graduates or student doctors in their third or fourth year of medical school as a requirement to enter medical residency in the United States. So starting around 2004, the exam was mandatory for all graduates, anyone looking to enter medical residency in the US. As to what the exam actually looks like and how it operates, it is a day-long exam. It's about 8 hours, and the 8 hours is split up into separate clinical encounters with mock patients, people who have been given a script. They are actors who are trained to respond in certain ways to questions that the student doctors ask, physical exam components, aspects of medical management at the end of the encounter. And then after the encounter, there is a brief period of time allotted for documenting the findings, documenting the next steps of management of the mock patients. Each encounter is allotted 15 minutes, so the day is split up into these 15-minute increments. After the examination, it takes about a month to get the results back, at which point you receive an email from the NBME, the National Board of Medical Examiners, giving your grade report, which is categorized into 3 different areas: one for spoken English language proficiency, one for communication skills generally. And the third area on which you're graded is called the Integrated Clinical Encounter, which sort of is an umbrella term that encompasses all of the skills that you displayed during the 15-minute examinations, the separate 15-minute examinations. So that encompasses your ability to take a medical interview, your competency in physical examination techniques, your ability in terms of counseling patients and medical management, and your documentation of your findings. Each of these 3 areas you receive either a pass or a fail. There is not a numerical breakdown. You're not assigned a score from 0 to 100, for example. You receive either a P or an F, pass or fail. And you need to pass each of the 3 areas to pass the entire examination. If you fail any one of the 3 areas, that is a fail on the entire exam and you are forced to retake it. Currently, the Step 2 clinical skills examination is $1,280 as a testing fee. It is only offered in 6 cities in the United States. They have seven testing centers total. I believe there's 2 in Philadelphia, 1 in Atlanta, 1 in Chicago, 1 in Houston, and 1 in Los Angeles. These are the only testing centers in the United States. If you go to a medical school that is any significant distance from that, the burden is on you to cover travel expenses and lodging in order to take this exam. And again, the examination fee is $1,280. If you fail and you need to retake, you have to pay another $1,280. So the cost of this examination that falls on the shoulders of the medical students that are taking it is significant.
So my understanding dealing with this exam is becoming a licensed physician it's a stepwise process, and this is just one of the steps within this stepwise process to become a licensed physician. Is that right?
Right. There are 3 step exams called the Step 1, Step 2, and Step 3. Each of them is required for physician licensure in the United States. The Step 2 clinical skills CS exam is one component of the Step 2 exam. The other part is the computer-based multiple choice question test, which is what the Step 1 and the Step 3 are as well. Step 2 is the only step in the process that has this mock clinical component to it, which is the CS.
One thing I found surprising about the exam also is that the pass-fail is all you get to know. It doesn't provide a medical student undergoing the test any meaningful, detailed feedback that's personal to them. If they were wanting to improve or have a critique that they could take back and learn from, it gives no value in terms of any detail about your performance.
Yeah, Hillary, I think that's really interesting. I think with you kind of mentioning that it's more pass-fail and unable to get some of the specifics maybe to guide further growth and development. But, guys, I got to ask, since the topic of discussion seems to be regarding kind of debating the validity or should we have this test, let's really just dive right in. Let's talk about what is the controversy behind this test.
Before we move in that direction, and is a direction that we should move. But to add to what Hillary mentioned about the feedback and the importance of having a transparent scoring rubric and how the lack of one not only makes it difficult for students to improve on their performance based on the results of this test, it's also a crucial element in terms of the ability to prepare for this examination. When the scoring system is this inscrutable black box, students do not know how to prepare for it adequately. There's no way to know, how should I prioritize my time in this 15-minute patient encounter? Is the physical exam items going to be weighted more heavily than touching on every point of a detailed clinical history in the history taking portion? Should I dedicate more time to counseling patients, or will I be graded more heavily on my ability to document the encounter? With no ability to properly prepare for this test the way that one can with the other multiple choice exams, which have numerous preparatory materials that allow you to ascertain the likelihood that you will or will not be ready to take this exam, whether you should expect to fail or pass, or expect to score well or score closer to the median of what students perform at, is not possible. This is so important because a failure on any of the step examinations is enough in the world of highly competitive medical residencies to be denied an interview, an opportunity to gain acceptance into a residency position. With residencies in the United States currently being as competitive as they are, any one blemish, no matter how slight or ultimately meaningless on an applicant's record, is sufficient for many programs to say it gives programs a reason not to interview an applicant. So this is much more than just having to repay the $1,280. It's more important than having to study and take time out of your schedule to take this test again. For many student doctors, it is a matter of whether or not they will get accepted into a residency program, not just of their choice, but in some cases, the possibility of not getting accepted to advance in their career at all. So this is, in fact, an incredibly high stakes medical examination that has been made part of licensure officially, but then unofficially part of the track of advancing into a medical residency of choice as well. There's a real chance that a student who performs very well on all of the medical school clinical examinations, is a good student, will go on to become a great doctor, could be prevented from doing so based on the results of this exam because it is so difficult to know how to prepare for.
Mm-hmm. I think the cost aspect has been well discussed. That seemed to be, the main force behind the initial petition. I just took step 2 CS in July, and after taking the test, my main concern now does lie in the fact that the feedback is lacking, and so that's a great detriment to the students that are putting so much money and time into this exam, and we don't get anything back for it. And as you may have discussed already, the validity just isn't there. The test was essentially validated by the MBME in-house, and around 2004, the test was approved, even though there were many, many people saying, wait a minute, we still don't have a good validated product. It only minorly correlates with, communication skills of first-year residents. So, how valuable is it?
I would totally agree with and expand on that, saying the test is not only overly costly, but of very low value, but it really doesn't correlate with meaningful objectives. It doesn't correspond in any studies to predict satisfactory performance in future training environments or as a practicing physician. And let's face it, most medical students from the United States pass this their first time, 98% first-time pass rate. At what cost? So the medical students are already taking better examinations in their local medical schools that do the same thing, then have to travel far away at a high expense with little value to do this all again for no meaningful outcome. So I would argue that not only is this a very useless test in general, but it doesn't serve our patients well. I'm a practicing physician in a healthcare environment that's a training environment, and what we need are clinical skills that are designed for our future workforce needs, not yesterday's.
Hillary, you published an article in the American Medical Association Journal of Ethics discussing the drawbacks of the Step 2 CS exam. And back in 2003 was when this was just as the test was becoming formally implemented for American medical school graduates. Can you tell us a little bit about this article, why you decided to write it, and your understanding of how your predictions have held up since you wrote it?
Yes, the article was very predictive of what has come to pass. In 2003, I was part of the American Medical Association medical student leadership, and we were very concerned about this exam coming on. And we worked very hard to understand its implications, understand the evidence behind doing it, and work with our partners throughout the House of Medicine to make sense of its implementation. And at that time, as was mentioned, it did not make a whole lot of sense. And this article, even before the exam was rolled out, predicted that it would be high cost, low value, not impact quality and safety, and be part of the educational testing system in America that is not a success. So I'm just amazed over 10 years later, 15 years later, how much of this article is still valid. And it really goes to show that forethought in testing, more forethought is needed, and perhaps more technology.
Yeah, I think that's really interesting, Hillary, the more you kind of talk about that. And I know we were talking in the pre-show about how the AMA has even come out saying overwhelmingly that needs to change. So I guess my follow-up to kind of gain some context for our audience is, why do you feel that this change, it's been over 10 years since this article came out, why have some of these changes, if it's been so very heavily, if there's been a lot of argument against that from students, from even the AMA, why has this overall really not made significant change since this article, or since the test for that matter, has been implemented?
Well, my opinion would be that there is a driving force amongst licensing organizations in the country to make effort to demonstrate that their testing systems are needed for patient safety. However, testing has not directly been related to that, and our modern understanding of patient safety goes well beyond one examination. It involves our skills in working in interdisciplinary teams, care coordination, managing data analytics, and working to serve the needs of the health of populations. So I imagine that the traditional forces that drive the testing industry have not kept pace with the modern needs for medical education and healthcare delivery in America, which is changing rapidly and has to change based on its economics.
Yeah, there's a lot to cover here and a lot to expand upon. I guess to verify and validate what Hillary just said about the test not being linked to what we really care about, because we can talk about not getting feedback from the test all we want and how it doesn't help us improve. What the defenders of the exam claim, and that would mostly be people who are affiliated with the National Board of Medical Examiners and clinical exam administrators at some institutions across the country, say that this is the sort of like the low bar that you have to pass. This is essentially a screening test to try to weed out people who might be ineffective clinical practitioners, who might harm patients. That is the function of the test. And everyone who defends this test says the main thing that it's for is to protect the public. But that has not been borne out by any of the evidence. The big review was done in 2016 by Archer in BMC Medical Education. That did not look at the Step 2 CS specifically, but it was a large sort of meta-analysis of nationalized licensing examinations for medical graduates. And they did not find that there was a cause and effect relationship between scores or pass rates on national licensing exams generally and things that we care about in terms of protecting patients, complaints or suits claimed against physicians for malpractice. Those things, there's not a cause and effect relationship. Now, there's more recent articles, such as one in 2018 in Academic Medicine written by Burdick, Boulay and LeBlanc. Again, these people have affiliations with the NBME. That seems to be the only people who are contacted to comment on this test. People who are outside of that sphere, people who have actually taken the test, first of all, people my age and James's age, and also people like Hillary, who, even though they have been practicing academic medicine for a time now, but do not take this standpoint, you don't tend to hear these voices. But the people who do defend it will sort of cherry pick articles and say there's a correlation between pass rates, scores on these exams, and real world outcomes. But when you go to the actual literature, this just does not stand up. And you can look at the articles that the NBME has published themselves, including the ones by Winward and Cuddy that James referred to. Those showed an extremely weak correlation. I think the Pearson correlation coefficient of 0.3 or something very small between performance on these exams and performance in residency for those particular studies. To expand a little bit upon that, they can only do these studies because systems are already in place to evaluate clinical skills of residents in their residency programs, which is a much more appropriate setting to be testing doctors. It should not be in medical school with mock patients. It should be overviewed by their program coordinators and directors while they're seeing patients and doing chart reviews in the real world with actual patients. So the test is extremely redundant.
And all these articles we'll have in the show notes. So if you guys want to take a look at them, make sure you check the show notes. Is there anything you want to add to that, James?
Well, we've really covered the issues with the exam, but where do we go from here, and how do we actually enact any change? And the main issue with enacting change is that the NBME and the FSMB, the Federation of State Medical Boards, they together create the USMLE and support the USMLE. So both organizations receive money from these exams that they essentially have a captive audience for. And the reason that's such an issue is because the FSMB is a conglomeration of all the individual state medical boards. And the individual state medical boards almost unilaterally get to decide legislation, and they get to decide how physicians are licensed. So the individual medical boards get to say medical students must pass USMLE 1, 2, including CSCK and 3. That means that we are all, again, captive. And the reason I want to hammer this home is because when I initially contacted the Step 2 CS group out of Harvard, they said to me, okay, so you're going to pass this resolution with Wisconsin Medical Society, but what's next? And they said, contact your state legislatures. But it's really not the individual, like for example, in Wisconsin, it's not the Assembly and the Senate that decide the licensing. It's the medical boards, which again are part of the FSMB. So everything is stacked against us actually, enacting any change.
That's really, really interesting. And just to kind of ask, that you guys are mentioning this, I kind of want to ask one follow-up. So what is, if it's really made up by this one specific group that it's hard to get into, what's the alternative, and how do we get into those circles to actually get real change happen to kind of offset that financial interest that you mentioned earlier?
I'm happy to contribute a thought. I think a lot of us will not potentially be state medical licensing board members or FSMB members. It's a very small group. They're politically appointed, yet we can influence them. We can continue to serve as advocates, and practicing physicians and partners in all allied healthcare professions can potentially join James and get on board with advocacy campaigns. But I think it'll really take public pressure. That's what the FSMB and licensing board groups respond to. If we can get this information out beyond our small circles and to our patients and to our legislators themselves, perhaps we can encourage a little bit more rational approach. And I think part of it is asking the question, is this the best way to spend our time and money as society and as people in training? And I don't think it's the best result for patients. And I think that message needs to come across.
Yeah, I think that's a really good point and a really good way to kind of get at that, really making it kind of be more of a grassroots and get it out, the message out to many others to hopefully continue to influence change. But let's talk about some of the actions that you guys have kind of gone through to kind of help contribute to this. So James, I'd like to start with you here, man. So you led a charge which resulted in the Wisconsin Medical Society ratifying a policy to advocate for the elimination of the Step 2 CS from state licensing requirements for physicians. Now, do you think you could tell us a little bit of what specifically inspired you to do this? What was the process, and kind of where did it kind of last stand compared to when, where it is at now?
Mm-hmm. So basically, I took the ball that AMA and Step 2 CS and ran with it. They already had a resolution that had passed the AMA in 2016. So in April 2017, I was able to take a very similar resolution and get it passed with the Wisconsin Medical Society. So I was inspired by physician autonomy, medical school autonomy. And then where do we go from here? Where did I go from there specifically? Well, the interesting part is that Dr. Ken Simons is the head chairman of the Wisconsin Medical Licensing Board. And he wrote an article that Deland initially responded to. And that article is how I ended up meeting Deland. So that was really interesting. But I basically hit a brick wall in my state. But I agree with Hillary that the individual state resolutions are very important to continue public momentum and, shape the perception of this subject.
So I agree with James in that you just end up running into a brick wall in your state, because the most that you can sort of do is get this resolution passed by the state medical society, but then they have to try to advocate to the state medical board to change their policy, which, as Hillary alluded to, is a much more specific group that's there for a specific reason, and they are much less likely to agree with this policy that we are trying to enact. One of the reasons that is the case, especially in larger states, is because they sort of look to documents like the annual reports by the AMA, American Medical Association, Council on Medical Education. This report comes out every year. And when there's a national policy, such as the one that the American Medical Association has against the implementation of Step 2 CS, they will consult someone to try to study the issue further and try to assess the feasibility of whether the resolution makes sense or can be adopted. Who do they consult? Who actually gets to write these reports? In the case of 2017, it ended up being Peter Katsufrakis wrote the report on whether it was feasible to transfer jurisdiction from licensure of clinical skills exams from the national level to the local medical school level. Peter Katsufrakis is the current president of the National Board of Medical Examiners. He's worked his way up. He started back in 2012. He received a promotion within the National Board of Medical Examiners to a position where he was paid $421,000 a year. In 2016, which is the last year that you can find the ProPublica listed, publicly available because the NBME is a nonprofit, tax return data, in 2016, Peter Katsufrakis received $548,000 in 1 year. He's making a lot more money in 1 year defending and advocating for the National Board of Medical Examiners than most physicians make treating patients. And these are the kind of people who author the reports that now every state will look to try to see if this is a reasonable move. So I think that says a lot about the difficulty in trying to get a policy like this actually enacted such that the state medical boards will remove this requirement from licensure.
It sounds like obviously bias is a huge issue. Have they come out with that recommendation yet, that 2017 recommendation? Have they made a statement on that?
Yes, the report was very predictable. It was lots of arguments that defenders of the exam have already used, including this. The protect the public part is always the underlying main theme that they try to hit on, which we've already discussed, and that is not a valid point to make. So so-called experts, people who make public commentary on this, I think you should just be ridiculed and publicly shamed for making that non-evidence-based statement because it's not true. But so-called experts and again, these experts tend to be the administrators and the NBME affiliates. They keep repeating this ad nauseum, but also they say that one of the reasons that they can't do this is because there needs to be some sort of standardization or equivalence in testing across medical institutions and medical graduates, some sort of common path to licensure, even though this exam was only made required in 2004, meaning that there are hundreds of thousands of physicians in the United States practicing who never had to take this test. And there doesn't seem to be any reason that we should entrust that people licensed before 2004, as opposed to after 2004, should be any safer or be any more of a risk of harm to patients, whether you graduated before or after that date. But also it sort of implies that this exam is able to be completely standardized and equivalent and get rid of any subjectivity. That's impossible. There's a large difference between something like a multiple choice test and something like a clinical skills mock patient exam. With a multiple choice exam, a multiple choice question, it can be administered in the exact carbon copy way to everyone who's taking the test. And every test taker's response is interpreted the exact same way. The only way to do that with this sort of clinical skill exam would be to have the exact same standardized patient, the same person acting as a patient, and have every single medical student in the country perform their clinical skill exam with that patient for that particular clinical scenario. And then not only that, but to have the same grader, the same presumably physician behind the black glass who's observing you and grading you such that it's administered and graded the exact same way across every student. And even that isn't completely standardized or equivalent because there's variability between the grader and themselves. They've shown this back in 2009. Redelmeyer ran a study that showed that when they do these interviews for admissions into medical school, that something as seemingly unrelated as whether or not it's a rainy day outside can affect greater perception of applicants so much that it can make the decision, it can be the cutoff between whether an applicant gets accepted or is denied admission into a medical school. So these are the kinds of things that are, again, just we need to admit that these exams are very subjective, and there's no reason to think the NBME and the USMLE can do it better than the local medical school level can achieve these criteria that we're evaluating. The way that Hillary alluded to this sort of business and corporatization and the industry of medical examination as being very much a profit-making, beneficial enterprise for certain people to get on board with, that's really bared out if you go look at the tax returns for the National Board of Medical Examiners. The president, Donald Melnick, for many years in a row has made over $1 million a year being president strictly for his duties of being president of the National Board of Medical Examiners. Right now, again, it's Peter Katsouforakis, the person who's written so much and has so much influence over the public debates about whether this exam should exist. The NBME does things like pay for social club benefits for their presidents. They have things like they pay for first class travel both for members of the NBME board and their spouses when they have to travel and stay in other cities. They engage in tax indemnification gross up payments, which are well-known mechanisms for increasing executive pay while concealing it from being able to be reportable income. So this is a when you look into the details of this organization, it's pretty dubious. And it's almost been strictly people who have ties to this organization who have set the tone for the public comment on whether this should be an exam that every medical student across the country is required to shell out $1,280 for and stand substantial risk if they fail it.
That's interesting. And is there like articles, or is this available easily online to kind of find that similar information out so that our audience can see as well?
Yes, because the National Board of Medical Examiners is a technically non-profit institution, they have to release their tax data. You can just do something as easy as search on the search engine NBME tax return. ProPublica lists all of the tax returns going back to 2001 up until currently 2016. So you can even track just how much money has been generated over the past 15 years. And you can compare it to things like rate of inflation and see how profitable this enterprise is.
That's really, really interesting to kind of get that perspective and to hear that. And, guys, I know that you guys had mentioned a couple key things of the evidence behind the test earlier, so I don't want to be redundant, but I want to ask just to kind of see if there's anything more on this. Is there any more that exists other than what was talked about earlier that talks about any of the other additional things regarding evidence behind this examination?
I looked up a lot of information about the positive aspects of local medical school run objective clinical skills exam. And what's interesting is you can't find anything unique or different or added value of a national exam. All of these objective clinical skills exams seem to weakly correlate with future performance in terms of exams and ratings by people who are working with you when you're in future training. So it seems to be a little added value that a national clinical skills exam provides when you look at the compendium of outcomes data. So it is, I agree with everyone who says this, public perception and who's driving the messaging does matter. But I really think it's important in today's environment where the high cost of healthcare is driving such rapid paced change for what we need in our workforce training, that this is not where we need to be spending our resources as a society or as trainees, or it should not be driving the curriculum of medical schools. Medical schools need to innovate and change beyond a physical exam. So it's just a misplaced focus that's totally antiquated and outdated for modern times.
It's also well known within the community of quality insurance and quality patient safety and quality assurance within the area of healthcare that 85% of medical errors are systemic errors and 15% come from individual clinician mistakes or errors. So why would we focus on the 15% that we really can't even assure by trying to pass this minimum bar of a standardized clinical skills exam when 85% of the mistakes and errors in healthcare are due to systemic problems, things like electronic health records, transition of care, patient handoffs. Those are the things where you want to invest your resources if you want to make a difference, not in the 15% of individuals who really, there's no guarantee that someone who passes this exam wasn't just acting as much as the patient who is paid to be there pretending to be the patient actor. The patient actor may be just as fake as the actual medical student taking this test. It's very easy to act your way through this exam and then completely change your attitudes, behaviors, interactions with patients once you go out into the real world and have to see patients and have to adhere. When you know that you will not have some governing body looking over your shoulder determining whether you advance in your career. This is like taking a driving test. You can act your way and be very cautious when you know that someone is in the car with you and they're determining whether you get your driver's license. It's very different when you're not being watched and you're free to speed, run stoplights, behave in the way that you would otherwise.
Well, this is the era of health grades and Yelp, and no one's exempt. My ratings, star ratings are online. So in the real world, your patient experience ratings matter quite a bit. And this exam has nothing to do with that. The 2% of medical students who perhaps each year fail it, who are from the United States, there's no correlation that they cause any medical errors any more than anyone else does. So you hit the nail on the head when you said it's an artificial situation that doesn't correlate with meaningful outcomes. But in real practice, our patient interactions and our patient experience is a huge deal. And in real world, it matters a lot. So I don't think people have any interest in healthcare of driving in the wrong lane because it will come back to bite you in more meaningful ways than a test score.
I think it's really interesting that we've been talking a lot about the evidence behind this exam and how it's really not an evidence-based exam. And the reason I find that interesting is because, medicine is seen as such an evidence-driven profession. And, in physical therapy, this standardized clinical examination has come up multiple times over the last couple of years as potentially being implemented to standardize expectations for practice for new graduates coming out of PT school. And I'm wondering, and maybe you've alluded to this throughout the talk, but based on your knowledge of the literature, its application towards medicine, how would you advise the profession of physical therapy going forward in potentially implementing a standardized clinical examination?
Don't do it.
Short and sweet and to the point.
James, do you have any thoughts on this? Because I think this is really important because as you can probably attest, James, the most important move in all of this is to never implement it in the first place. Because once the gears are in motion, they're very hard to stop, as you found out.
Yes, as you alluded to earlier, I think the more appropriate place to evaluate clinical skills and improve clinical skills is likely in residency. If you do so in medical school, you are preventing each individual medical school from creating a curriculum as they see fit. And I'd also like to mention that in Dr. Ken Simon's article, he creates this straw man argument about the student who is robotic and just completely unable to interact with patients. And I think that's a very cynical and empty argument. I think every individual who is able to get through medical school should be able to be taught with a good education and with a good exam. Every single person who is able to get into medical school and graduate should be able to be, quote unquote, rehabbed. And I think the proper place to do that would be in residency. But again, probably not in a centralized exam, probably in something that each individual residency, or at least each individual specialty.
Well, and I find it interesting too, and I don't know if you guys are how familiar you are with the profession of physical therapy and kind of what our academic institutions are like. But as physical therapists, we come out of school, out of our doctorate program, ready to practice as physical therapists. Residency is not required. We carry a full patient load by the time we're in our last clinical rotation, whereas in medical school, as medical students, you never carry a full patient load. You're lucky if you really actually get to really treat a patient or do something more than just take a medical history. So I think that the differences that it should be alluded to, the differences between medicine and physical therapy as far as what needs to happen with a standardized examination.
So I think that raises an interesting point that if we're wanting to select people who fit humanistic qualities and characteristics for empathy, communication skills, that can be done at a much more upstream point. You can change the prerequisite courses that are required for entry to physical therapy school or medical school to select for a different set of personality traits, perhaps. The testing that what is required to get into the professional training schools plays a role here. There are different ways to weed in, weed out different traits in who is in the medical profession, allied health professions. It does not have to be all dependent on a high stakes exam that's done at the end point. It is probably much better done much further upstream for selecting the type of people that we want to be in healthcare today.
I want to reiterate, just because I know a thing or two, because Stephanie and I are married, about the possibility that a test like this could become a reality in physical therapy. And my only comments are that the most important thing, if you're going to try to do something, you want to try to do it before it is implemented. And I just want to reiterate that heavily. James mentioned that it was very much a unilateral decision to incorporate Step 2 CS into the licensure requirements. Hillary was a part of the group of people who really tried to do something about that before it happened, and no efforts from professional organizations, AMA, AAMC, none of it was enough because one group, one arguably very self-interested group, had complete power over whether this became a reality. That being said, if you are in a position to maybe be influential, try to make this change, or try to have a voice in this debate, you want to do as much as you can before the rubber meets the road, so to speak, before people are lining up, going onto the internet, signing up, paying their $1,000, and they are required to show up at the testing center. Because once it's in place, and this is what has been very unfortunate to see, is that even the few times when a high-profile person has come out and written a high-profile article about why the Step 2 CS is not necessary or not a good decision. I'm thinking of Lehman in the 2013 article in the New England Journal of Medicine, arguably the most high-profile publication that you can get in the field of medicine is in New England Journal. Well, him and his colleague wrote about how it's a core value proposition. They were saying that that's where the number of $1.2 million per double-failed student came from. The argument being, we're spending over $1 million to try to catch one person who fails this exam twice. Why are we spending all this money? If this were a medical intervention, people wouldn't have it. You would never pay for this. That ended up getting almost turned around into, oh, well, all we would have to do to validate and justify this exam is to increase the failure rates, make it harder to pass. Because now, instead of 98% pass rate, it's now a 92% pass rate. And that automatically, by doing nothing to change the test at all, and to add nothing to the justification for why it protects the public, you have now reduced the number of dollars you're spending to catch a double-failed applicant who's taken this test. And all of a sudden, you have an automatic response to someone who managed to get a New England Journal article written against this test. So this has actually come to fruition since, I believe, Hillary has written on this subject. They actually changed the test criteria and grading in such a way that, and this is only within the last year, calendar year, I believe, from a level where 97% of students were expected to pass, American, United States, domestic students were expected to pass, to now a threshold where only 94 or 93% of students are expected to pass. So they're going to double the failure rate. And it's going to, unfortunately, achieve this, sort of address this problem that Lehman brought up in 2013 without further adding anything truly material to justifying this test.
That's terribly unfortunate. It seems unfair to the medical students who are affected, and also has potential unintended consequences of driving curriculum in medical school in the wrong direction, geared toward a test, like as you mentioned, has no defined grading parameters, is a little bit subjective with inter-rater variability in its nature of its grading, and serves little purpose in matching to meaningful outcomes. I'm sad to hear that.
Yeah, I mean, guys, this has been a really, really interesting discussion, because I think I've definitely learned a lot about A, medical education, but B, this exam and a lot of the things behind this. And I really must echo and respect everyone's points here about how really there's a need to really push for change. But guys, we like to ask this final question to every one of our guests at the end of each episode, because we're just curious what everyone's thoughts are regarding healthcare education. So our final question that we ask is, if you could change one aspect of healthcare education, whether that be medicine or other healthcare provider related, which aspect would you change and how would you change it? And James, let's start with you for this one.
Well, first I'd like to put in a little plug for the Kern Institute. It's a multi-million-dollar endowment here at my school. And so my school actually has many faculty now working with 50% of their time to change education, hopefully on a national level. What I would like to do specifically is decrease the amount of general education that medical students receive so that specialization can occur more quickly. I think that the vast majority of medical students can be happy in multiple specialties. So I think the idea of falling in the wrong specialty is probably incorrect. So I think you can specialize earlier. And because, you know, the medical knowledge that we have is doubling, like, I think it's like every 8 months, we can't keep up with this huge bloated, first 2 years of general education before even getting into clinicals. So that's the short answer. I would decrease the amount of general knowledge we need and start more with understanding how to learn and then specializing.
If I could wave my magic wand, I would reinvent the governance structures that oversee medical education requirements. We are at a time, as James mentioned, of need for great innovation in medical education throughout the continuum, and the evolution of fragmented, independent organizations with conflicting interests for every step of your training from undergraduate to graduate and beyond, I think has led to a system that doesn't make sense anymore.
I'll be very brief and mostly agree with Hillary that I don't really like the premise of the magic wand question, if you could wave a magic wand, but if I could, that's because I don't know how much going backwards there is. Once these systems and policies are ingrained, they're almost impossible to change some of them. And James makes the point that we need to probably have a structure that is more adaptive. I just don't know if there's a lot that I can add to what either of them said. They both make good points.
Well, thanks you guys so much for joining us today. This conversation has been extremely enlightening. I hope that our listeners have learned a lot from it. You know, if people have questions in the future, a lot of times they do contact our guests. How can people contact you or find you on social media if they do have questions relating to this topic?
I guess I'm on Facebook, I'm on Twitter, I have a very unique name. So if you search my name, I'm pretty much the only person who comes up. And I respond fairly quickly if anybody wants to get a hold of me. My email is deland.wyrock@yale.edu. You can also find that if you search the Yale departmental website.
You can find me at jsprice@mcw.edu. That's basically it for me.
My email is searchable as well. It's hillary-johnson@uiowa.edu.
Perfect. And the links to all those will be in the show notes, guys, for anyone who's interested to kind of ask a question. So again, guys, thank you so much for the time and for all the work that you guys have done throughout this endeavor. But thank you for everything you guys have done. Keep up with the good work and such. And then thank you for coming on.
Thank you.
Thank you.
Hey, everybody. Thank you for listening to the Healthcare Education Transformation Podcast, as we greatly appreciate your support to help us advance healthcare education. We are very happy to announce that we have created a new tool to help develop clinicians into better experts. With that being said, we have created the HET Light tool, which LIGHT stands for Learning Integrated Towards Expertise. And what we've done is we've taken our first year's worth of episodes with experts in the fields of healthcare and education, and we've taken one golden nugget or theory on expertise and presented it to you in a very easily consumable format so that people can take one lesson or nugget per week and map out and plan how to incorporate it into your clinical and educational practices. And by the end of the year, we think you'll be pleasantly surprised at how far you've progressed towards becoming an expert. To find out more, please check it out at pteducator.com/HET, which is also available in our show notes. Thank you again all for your continued support. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.